All right, you're
All
good.
right, great. Okay, let me introduce you guys. We have two students who are seniors at Weber State. Weber State, great, great, great. That's where I graduated from. We have Braden and Emily, and they are in the radiology department. And they wanted to come and tell you guys all about what radiology is, future career. So let's congratulate them for getting to school. Oh my gosh, they drove quite the distance to get here. So let's thank them in advance for coming. So thank you, thank you. All right, okay.
Okay, like she said, I'm Emily and this is Braden.
Oh, let's pull up that slide.
Hold up. But yeah, we're from Weber State, the Dumpke College of Health Professions, the radiology program. We're just going to talk a little bit about like Weber's radiology program, kind of the specialties that Weber offers, what we do as radiographers, that kind of a thing. If you have any questions, feel free to ask.
Sorry. Oh no, you're gonna see all their stuff. Do you guys catch all of it? All right.
All right. So, the program that we are in the radiography program. This is the entry-level program for the School of Radiologic Sciences. We're just going to talk about what we do, what we need to know, and then where to go after. So the basis of X-ray, what we utilize is the electromagnetic spectrum. Some of you might know, it might not. It works with radio waves, infrared, visible light, ultraviolet, X-rays. So ours is on the high energy spectrum. You notice that because these wavelengths shorten, higher frequency. These photons are so high energy that they can actually go straight through your body and be stopped by certain objects such as bone. So the radiation either travels through you or gets absorbed. And without that absorption, without radiating your body, we wouldn't have pictures.
Okay, so what do we do as radiographers? Basically, as a radiographer, you are concerned with radiographic positioning, which you have to know your anatomy, you have to know your landmarks, you have to know how to position your patients to get the views that the doctor wants. We need to understand radiation physics, so we need to understand how X-rays are formed, how they interact with the body, so radiobiology, and we need to know how to set our technique, which is basically we decide how much radiation we're going to give the patient and at what power or energy we're going to give the patient. We also need to know about radiation safety. We use a principle called ALARA, which is as low as reasonably achievable, and that's just what we use to kind of judge how much radiation to give our patients. We want to give them as low, like a low dose as we can, while still getting a quality picture. And we do that by using time, distance, and shielding, and that will protect us and our patients from radiation.
Interesting thing about the X-rays, we get the order from the doctor, but we actually prescribe what their dose is, based on their size and all that other stuff. So, we work with a lot of different equipment, different brands, different types. It's a very advanced technological field. We'll kind of touch base on a few of the instruments that we've used and how it's changed even over the last 20 years. If you've ever had an X-ray, generally you would be in a room like this. There's a few pieces of equipment that we need to know about. This is the wall bucky. This one is for any upright imaging. For instance, if you're doing a chest X-ray, the patient will put their chest against that board, then we take our picture. Other thing here, we have our X-ray table. There's a bunch of buttons on the bottom here. There's one that if you click it, it'll free move the table. This is really nice for if you're taking pictures of somebody's like broken femur. We don't want to move them around or have them stand or anything funky like that, so we can put them on the table and position them wherever we need them. It's a lot easier for the patient. As far as the X-ray production, that is coming from this section right here. So that's called the X-ray tube. That's supplied with a high voltage of electricity. And what that does is it gives us the ability to actually make X-rays from atoms.
Okay, and then this is a C-arm. This is what we use in the operating room. So we actually go up during surgeries. A lot of times they're like trauma surgeries or like orthopedic surgeries, and we assist the surgeon while they're placing rods and screws and different things inside the patient. We use this machine. It looks like a C, that's why it's called a C-arm. And basically, we're able to kind of drive it in and out of the sterile field. We're able to rotate it around and different directions to help get different views of the hardware that the doctor is placing. So basically, we're not sterile. This would be like the radiographer, and that's like the surgeon and like the assistant. They're sterile, and we kind of operate around the sterile field, but while they're doing surgery.
Interesting thing, this is relatively newer. Some doctors decided, hey, my patient's way too sick. They cannot come down to the radiology department, but we need an x-ray. So, this is an x-ray on wheels. We get to go to the patient's room. It's an interesting technology because the detector that we use that actually accepts the photons, we can pull those right now. So these detectors, for instance, if we were going to go do a portable hand, we could bring it up to the patient's room, put their hand on this, take the picture, shows up right on our machine so we know if it's good or not. This is where technology has changed a lot. So Emily here has one of the really old detectors where essentially it's just a protected housing that they had to stick film in. The film is ancient technology. We don't deal anything with that at all. This next one here is similar in design, except this plate right here is made of a different type of material that can actually take the x-rays, hold the electrons in them, and then we scan it with an electronic reader, and then it gives us our picture, but it still is a delay. The ones that we have nowadays look almost exactly like this, except we take the picture and it pops up on our machine. Really fast, really nice. The change from the film to this to our current just digital, probably since early 2000. So really, really new technology. So we're gonna go ahead and just show you some pictures of what we do, and then we'll go on after that and show different modalities and what you can do after. This section here, we have a lot of handouts. Candy, pens, stickers.
Candy.
So, let us know. Feel free to answer any questions, ask questions. Would you mind grabbing the light?
Does this work better with the light out, do you think?
Yeah, I think so. I think it's a little easier to see.
You can have cute little rubber ducks that look like doctors. How many of you are interested in radiology off the bat? A lot? Yeah. Sweetness. This is the right presentation for you then. So, this is where we get you guys involved. This is an x-ray of what? Lots of structures we've mentioned. If you speak up, we'll throw candy at you or whatever. We've got ribs. What else we have in there?
Spine.
The spine.
I can
We've got spine.
collarbone.
Collarbone, otherwise called
Clavicle.
clavicle. Other than bones, can we see anything else?
There's the heart.
The heart. I'm terrible.
It's okay. What about
There we go.
these darker areas? Lungs, who said that?
The lungs.
Nice.
Great. So, what separates the chest from the abdomen? If any of you know, I don't know if you've gotten there yet. The diaphragm. Beat you to it. So, since you know that that separates the abdomen and the chest, there is something here. It's a dark area. Anything that's dark has air in it. Any ideas why there's air below the diaphragm? And what structure it's possibly in? You're right. Yeah, so that is a thing. There is almost always air in the fundus of your stomach. That's the top part that sits right below the diaphragm. We'll go on to this next picture. It is another chest x-ray, but with something a little different on there. What is different? And if you know what it is, shout it out.
Like a pacemaker.
Pacemaker. So this piece right here, x-rays are 2D. So it's kind of hard to tell where it is. That's another thing that we need to know of is if we see one of our pictures, we need to know what we're looking at. So the pacemaker, this device is actually implanted right underneath the skin here. outside of the rib area. There's these things that we call leads, and they go down into the ventricles of the heart, sometimes other places, and that essentially just creates an artificial conduction of the heart for anyone that has like an irregular heart rhythm. I heard someone shout it out. Baby. So this is an example of when we'd go to a portable x-ray. This is actually with this machine up in the NICU. And one of these things that we always have to do is, this looks like a fresh baby, we know, because they have to mark at what gestational age the baby was born at. So this was a 38-week-old baby. What part of the body are we looking at? Any guesses?
The pelvis.
Lumbar. I heard pelvis in there.
Vertebral column.
Yep,
Sort of, right?
kind of, yep. There's also soft tissue. I heard intestines. Who said that? Someone said it. They're shy. That's okay. So it's an abdominal x-ray. There's something funky in here. Can anyone point it out? There's a few things.
There's a baby.
There's a baby in there. There's one other thing that people usually point out. What are we seeing?
The baby's not head down.
Hmm?
Is the baby not head down? Is that a problem?
That's fine. They're okay where they're at. Does anyone notice something by the baby's head? A big white area. Any guesses what it is?
The umbilical cord.
Nope. Not a tumor. That's usually the guess that people make. So this mom's story, she actually came in, she had no idea she was pregnant. She was just having a lot of kidney pain on that right side. And interestingly enough, all this white area, what they did is they injected what we call a contrast in their vein, and it gets filtered from the blood into the kidney. So they were checking her kidney function and why she was having all that pain. And it turns out that the kidney dumps into the ureter and the baby's blocking it off. So they took this picture and said, hey, your baby's blocking off your flow. There's nothing we can really do, and they're not going to x-ray anymore because we don't like to x-ray babies while they're pregnant. Speaking of kids, there's a wedding ring, expensive. So kids experience the world by putting things in their mouth. I don't know if you've ever noticed that. Like, kids grab things and it goes right to their mouth. Wedding rings are no exception. This is something, they would probably track it as it goes. Generally, they just wait for it to come out. So, if it's causing any obstruction or like any extra gas in the belly, they may do surgical operation.
But we take lots of x-rays on kids who have swallowed stuff.
Oh yeah.
Usually like coins and clips and stuff.
This is where things get fun. What is what? What are you looking at?
The string.
That little string there?
It looks like a fish hook type thing.
What are you thinking here?
I don't know.
Close, but no.
The world's largest cell.
So it is outside the patient's body. It is actually a heart monitor, just a cord that's stuck on their skin. Normally, we would take these things off. I'm assuming because this patient is very painful. Now let's start looking at other things. What are we noticing? They probably left the cord on because they're super painful, super sick.
There's a circle
What circle?
in the
Do you know this?
Right there?
above the pubis.
Yep. We said that earlier. Anything that's darker is air. So that's just gas.
Oh.
Yep. Are they hurting? Are they broken?
Their bone broke.
Which one?
The ischium.
Ischium. So the ischium and the pubis are broken. On one or both sides? Both. Yep, so you can see that inferior ramus and the superior ramus are broken straight through on both sides. There is stuff happening over here. We'll touch that in a second. So the hip's actually not out of socket. What you're seeing, if you compare it to the other side, see how there's this nice crisp white line? That is called the acetabulum, if you guys remember that. So this side is very broken. So they actually broke their acetabulum. If you're going to break this, you're most likely going to break your hip as well. So they've got a intertrochanteric fracture in that area.
What did they do?
So this, we don't know the for sure story, but to do this many breaks in your pelvis is really strong. Some sort of high energy accident, whether it's skiing, car accident, falling from a great height. Who knows? I wish we knew the story. Again, we don't even work with these. These are older
these are
than we
from
are.
so long ago. Who knows what we're looking at? What bone this is?
Tibia.
Tibia. What other bones in the area? Great. Which one's broken?
Tibia.
Okay. How do you know the difference between the two?
It's bigger.
Bigger. So this one is a lateral picture. A lot of what we do in X-ray does have to deal with the body plane. So all that mid-sagittal, coronal stuff that probably went right over. I know it did for me. We'll come back to you if you're under radiology. So it's lateral. We know that because of the femoral condyles. They're seen in profile, so the picture's taken like this. So this is an example of something that is a comminuted fracture, but we can do surgery on it. That's something that we can fix. These are some of our intra-op pictures. So this is what we use with that C-arm that we showed you a while ago. This is where we help guide the physician of putting all the metal in the right place. So this rod in the tibia, actually, what they do is they bend the patient's knee way up, essentially like yank it out of socket a little bit, and stick this rod right through the top of the tibia all the way down. So that's another way we can fix stuff.
Screws to put in place.
Yeah. We always have to take pictures in two different views. Reasons why, you see this one right here with screws in it. Yeah, there's screws, but are they in the right place? We know they are, because you can see this one. It's actually the sideways picture of those screws going straight through the holes. If they were anywhere else, they know they put them in wrong.
Alright, here is an example of bones we can't fix when they're too broken. So again, this is like another tibia and fibula. This one is from a motorcycle accident. The last one we just looked at was from like a car accident. This is from a motorcycle. And this is something that actually can't be fixed, that they did an amputation below the knee. Yeah.
Yep. There's no way you're getting any of that back together.
just-
So
Super shattered.
does that look right? No. What's wacky about it?
Hyperextended.
I wouldn't say hyperextended, but it is something with the joint. Dislocated. Let's look at another one. Oh, I'm a terrible throw. You got it. So it is dislocated, but it's also fractured. So this generally is supposed to be like down here, like your tibia goes straight down through the talus. We know it's fractured because you can see the ends of what the tibia would be and the fibula are actually over this way. And those are the medial and lateral malleolus that are actually broken and dislocated with the ankle. So this is something that not only can you see it on X-ray, but when the patient comes in, you look at it and you know it's either broken or dislocated. So. This one's a bit tricky. It is not two different feet. It's the same person, taken at two different views. There are fractures. Can any of you tell me which bones?
Metatarsal.
Where at?
Big toe.
Big toe? That one, no. If we use medical terms, proximal or distal? Where's the break at? Distal. Yep, so there are arrows here. What you're probably seeing on that first metatarsal is those sesamoid bones that sit underneath. They're just the free-floating ones. But the second, third, and fourth, you can see are actually broken right there at the metatarsal's head. This is another reason why we do get two different views, because we want to see how displaced they are. So this one we call an anteroposterior view. Based on anatomy, it's going straight through that sagittal plane. This one is an oblique. So what we do is we actually rotate the foot about 30 to 40 degrees inward. And what that does is it lets us see all of these tarsal bones, where in here they're all just kind of overlapped. So, but it does help also show displacement of these. Which bones?
Femur.
We're just gonna get a lot of candy. Do you want a duck or a pen?
I'll take a duck.
A duck. Oh, you got it, sorry. Yep, so we've got the femur. Is it broken, dislocated, both? And broken? Yep. This right here, you can't really see it because it's kind of off the image. This is what we call an open fracture. Anyone familiar with what that is?
Did it go through the skin?
Through the skin. You guys got it.
Do you want to throw her something? She's answering questions. I just won't hit the camera.
You? So, the femur, really strong bone, also has really, really strong muscles associated with it. These tend to be open a lot because of that reason. So like when the bone breaks, you lose all of that structure, and the bones just, like you see a lot of diaphyseal fractures where the bones are just slid on top of each other. The muscles just pull them straight together. So that brings us to this device. That is what we call hair traction. So the ER or the ambulance crew can put one of these on. What they do is they basically pull from underneath the patient's knee as hard as they can to straighten those bones out as best they can. And then that device holds them in place. This patient was probably a lot more dislocated than this at first. This might have been like down here. It takes a lot of pain off of the patient to get those bones relatively close to where they need to be. This long part of the bone is called what? Who was it? You say that? You want duck? Sure. So the patient is broken, not in the diaphysis, but what area down here? You started it.
I know.
The epiphyseal plate.
Physical plate.
Yep. You haven't got. Start throwing. Why not?
Okay, I really don't know if I can throw that far, sorry. I'm in trouble throwing.
So we did talk about how we like to get pictures in two views. So the lateral view here, you look at it and you're like, yeah, it looks kind of wonky. But on the AP, the anteroposterior view, that's how you know which direction it is dislocated in.
Okay. Who knows what this is?
The cranial.
Yeah, pretty obvious. This is a lateral projection, so this is looking from the side of the skull. Basically, we're just looking for this right here to be lined up. Does anybody know what this is?
It's like
Not the ear, not your eye. Your eyes are going to be more forward. Anybody?
We'll give you a hint. If it was touched, the pituitary gland sits inside of it.
The temporal?
No, good guess.
Nope, not the zygoma.
it's the one with the circle. I remember.
Not sphenoid. It's not a sinus.
It's got a circle, yes.
circle?
Yes, it has a circle.
It looks kind of like a circle.
You might be thinking of the foramen magnum.
Yeah, not the.
That's the
very
occipital bone, that's actually down in this area. Further down. So this up here actually is part of the sphenoid bone. It's the saloturcica, that saddle, or I can't remember exactly what it's called, Turkish saddle. So that sits the pituitary gland. We want to make sure that's perfectly in profile because if there's any damage there, it's not a good sign. So, skulls are interesting to take pictures of because if I stuck a whole bunch of different shapes, like a star, a circle, an oval, on a balloon, your job is to take, let's say, a picture of the star as a perfect star, and then take another one where it's completely just a line. So taking a picture of the skull can be pretty difficult because you are working with a spherical structure.
Here's another view of a skull. Basically, it's like from the front. Interesting. Oh, sorry. Go ahead.
Anything stick out on this patient that they might be missing? They do have a face.
Part of the maxilla.
Yeah. They're not missing part of the maxilla, but you can look in.
But there
that
is this area that you kind of
something
zone
is-
down. There's something
yeah,
missing
something
there.
is missing in that area.
Not a cleft.
Why can't you see the teeth?
Because there are
They
no
don't have any
teeth.
teeth.
They probably had dentures. If they
Yeah.
do have dentures, we like to take them out, just because that's not technically a part of the patient's body. So they took the dentures out to get that picture. You essentially said it with your body. It is an elbow. Which bone is this one? Great. What about these two? Awesome. So, this one's a hard view. We won't go into too big of detail, but this one, we're assuming the patient was really broken in other places. So what they did is they just stuck really quick pins into the, what I'm assuming is the ulna, because this structure right here is the radius, but it's following along that part of the bone on the ulna. So they probably just pinned it, and they'll come back and do screws and plates and everything else later.
Okay. This is the last one. This is same person, just two different views of their hand.
Same hand.
Yeah,
Same
same
hand.
hand.
One's looking straight on, the other one's kind of tilted. It's kind of wacky. They're definitely broken, dislocated,
Just a bit, yeah.
just a smidge. What do you think they did?
Crush their factory accident.
Factory accident?
Yes.
Close. I guess not super close, but that would do something like this.
Look at these little white little specks. Those are metal fragments. Not a car crash.
Explosion.
Not an explosion, but closer.
That is closer.
Pretty close.
You get shot in the hand.
Shot in
Shot
the
in the
hand.
hand.
Yeah.
We don't know if they did it themselves or how it happened, but or if the gun like exploded in their hand.
Is the bullet?
There was some secret agent doing a mission.
Right. Interesting thing about this one. So not only can we see bones, this is another thing, as a radiographer it's kind of hard to see them, we see soft tissue as well. So that area, you can actually see all these outlines. It's kind of grayish, not necessarily white or structured. That is skin and muscle. You might notice there is none right here into the metacarpal area. So this patient, right down this area, about to right here is just open. So their hand is almost split now. So, be careful with explosives. Fireworks could do this too, so.
That's all I got.
Yeah, that's some fun pictures for you. I know Emily and I have both taken
We
many,
take lots of
many
things.
broken pictures, bunch of chests. We've seen most things related to the ones that we showed you. Any questions as far as pictures, how we take them, before we move on to what you can do after X-ray? Okay. There we go. So, we're going to talk about the program that we're in right now. For those of you that are interested, this is some good info for you. What to expect. We are in the radiography program. It is the associate's degree of radiology. We do 2 years, and it's 5 straight semesters. So you go you go fall, spring, summer, fall, spring, just straight through. That being said, we do 24 clinical hours a week, with the exception of like 8 or 9 weeks out of the whole year. So in total, from day 1 to the end, we do 1,464 clinical hours in a hospital taking x-rays on real people. That feels like a lot, but as far as the schoolwork, it might overwhelm you, thinking that you have a lot on top of it, which you really don't. You're only on campus at Weber for 4 hours a week, and that's it. So most all of your learning is actually just in a hospital. There are competencies you have to pass off. The clinical site that you're at has to make sure you know what you're doing and know if you're doing it wrong, so they essentially just have to pass you off. Like, you know how to do a foot, you know how to do a shoulder, you know how to do a skull. There is a national exam that you have to take at the end. This one, I think they slot you 6 hours to take it, somewhere around 200 something questions, and it could be anywhere from patient care, medical ethics, positioning, x-ray production, all sorts of fun stuff. But after 5 semesters, you get pretty comfortable with it. We kind of talked about all that.
All right, and then after you graduate from the associate's program, Weber does offer like 11 different specialty bachelor programs. We'll touch a little bit more on these in detail, but there's mammography, computer tomography, which is like CT or CAT scan. There's MRI, nuclear medicine, radiation therapy. There's medical and cardiac sonography and cardiac medical interventional radiology. And then they also have a bachelor's of advanced radiologic sciences. That would be like if you don't want to specialize into another modality, you can stay in x-ray but still get your bachelor's degree. That's kind of what that one is.
After your bachelor's, if you want, you can always go on and get your master's degree. Generally, this is people that are wanting to teach and or work on innovation and improvement of the science of radiology as a whole. So these are the people that are essentially specialists. They know just about everything. They work with governing agencies to change protocols, come up with new ideas, new technology, all that fun stuff. It's 3 to 6 semesters depending on your goals. So you can complete it in a real quick 3 semesters, or you can stretch it out. They're pretty flexible because by the time you're in your master's degree, you're generally older with kids and a life, which is really nice that they understand that. There is an emphasis in cardiology, and then there is what we call an RA, a radiologist assistant. These are really similar to physician assistants or PAs, but their whole job is just in radiology. That's kind of a newer thing that's becoming more accepted. They're generally still